Thank you. Next, I invite the next speaker, Dr. Anju Kuriakose from Chaitanya Hospital. She will be presenting a case of TB vasculitis.
Good morning to one and all present here. I am presenting a case of a 35-year-old young male came with sudden onset blurring of vision in his right eye for the past 2 days. No history of headache, redness, photophobia. No history of relevant past history or drug history. No positive uveitic history. No history of TB, pets, oral or genital ulcers, recent fever or cough. On examination, his best corrected visual acuity was 6.6 and anterior segment 1+ L's, otherwise within normal limits. Fundus of the right eye showed disc hyperemia with vessels appears tortuous vessels along all 4 quadrants with perivascular sheathing and significant retinal hemorrhages inferiorly with neovascularization with yellow elevated lesions in all 4 quadrants. Similarly, in the left eye, vessels were tortuous with retinal hemorrhages more extensively in the left eye with perivascular sheathing. Montage of both eyes on the first presentation. OCT over the choroidal lesion revealed a well-defined elevated choroidal lesion with heterogeneous reflectivity with RP elevation and outer retinal layer disruption suggestive of a choroidal granuloma. The provisional diagnosis of bilateral occlusive retinal vasculitis, predominantly periphlebitis with choroidal granuloma, was made. The patient was started on topical steroids, sent for blood investigations and planned for FFA ICG. He was reviewed with blood reports. All were normal except ESR. We went ahead with the ICG of the right eye showed multiple hyposynescent areas scattered over the posterior pole, suggestive of a choroidal granuloma. FFA and ICG showed hyperfluorescent spots, which is increasing in size and intensity, with showing capillary non-perfusion areas in the periphery in all 4 quadrants. Late phase showing extensive perivascular leak. Similarly, in the left eye, it was more predominant than the left eye, the more extensive leak and the CNP areas. Late phase showed extensive perivascular leak. Based on this FFA ICG, our first provisional diagnosis was sarcoidosis, seeing the multiple choroidal granulomas. Second was TB and the mimicker syphilis. So we went ahead with the more relevant investigation of QTB, which was positive, and AS and HRCT was normal. So the diagnosis of bilateral tubercular posterior uveitis was made. We sought the pulmonologist's opinion. So according to the COTS criteria, ATT was initiated with 6 months regimen. After 3 days of initiation of HGD, patient came with complaints of right eye pain and watering, which showed anterior segment showed diffuse congestion and edema superiorly with tenderness. Fundus shows hyperemia of the disc with circumscribed yellow elevated lesions temporal to the disc with SRF. B-scan revealed classic T sign. Diagnosis of right eye posterior scleritis secondary to TB was made, which is considered as a paradoxical worsening of the disease after starting the ATT. So he was started on oral steroid 1 mg per kg and reviewed after 1 week. Posterior scleritis had resolved with resolution of hemorrhages. This is fundus picture 1 week after ATT and steroid. FFA guided PRP was done under steroid cover and ATT. Thank you.
Thank you, Anju. Over to you, madam. How to proceed if you see a case of periphlebitis?
So in this, so whenever you see vasculitis, it's very important that you look for focal lesions because the implications are different. So if you see choroiditis or retinitis along with vasculitis, there's a high chance that you're looking at an infectious process rather than only vasculitis. So that's the first point. I'm very happy you did combined FFA ICG rather than FFA alone. I'm a strong advocate of doing a combined ICG for baseline, at least for baseline, when, you suspect a choroidal involvement. You didn't start, when did you start the oral steroids in this case?
After we saw this posterior scleritis.
Is there any reason why you didn't add steroids?
The patient was advised to come after starting of ATT to start the oral steroids after 2 days. But then on the third day, patient came with pain. So it was supposed to be started on the same day.
Right. So we have seen cases, of presumed ocular TB, but those are usually solitary granulomas, where we have asked the patient to start ATT and then come back for oral steroids, but the patient has actually come back after 6 months with resolution only with ATT. But the thing is, for most cases, especially I think when there is an element of vasculitis and it's a multifocal choroiditis, you have to combine it with steroids. So paradoxical worsening is well known in tuberculosis. And the pattern in which it most commonly happens is the serpiginous, like choroidopathy. This is a little bit unusual, but it can happen. Yeah, so for almost all my cases, I would combine ATT with steroids.
And how to differentiate between an infective vasculitis or is it an immune due to TB?
Yeah, so that's the eternal question, and I think, we are nowhere near, answering that question. But how much of it is the infection and how much of it is an immune-mediated problem? It's a huge challenge. Because I'll tell you an interesting case I've seen, a long time ago. That patient actually came with periphlebitis, occlusive vasculitis in one eye. And I went back and looked at the previous records, where they had consulted somebody else in another hospital. And, surprisingly, in the same area that patient had choroiditis before, which had disappeared, and was now presenting with vasculitis in the same area. I believe, this from my personal experience, I believe that the vasculitic component in TB is mostly immune-mediated, whereas the granulomas, they tend to be more of infective. But having said that, I'll also tell about one more patient of mine, who came with what looked like pure vasculitis, no choroidal lesion, no paravascular lesions. I asked for, Manto was positive, I asked for clearance, and I started high-dose oral steroids. He responded, and then he comes back with slurring of speech and difficulty walking. He actually developed a very extensive CNS TB, and it took more than a year, to bring the disease under control. So you need to be really, really wary.
Thank you, madam. And Dr. Archana, how you treat TB vasculitis there, or is it like it's no TB there?
There's no TB.
UK.
Of course we do, especially with the globalization and stuff. We are seeing more and more cases of TB. So it's always a multidisciplinary approach along with the pulmonologists who are interested in TB and other infectious diseases. I'm of the strong advocate that we need to definitely combine both ATT and steroids. And my colleagues are very supportive in the sense that they try to get to see the patient as soon as they can, because it's a long waiting in the UK, in the NHS setting. So how I would approach a case as to decide when to start the systemic steroids is by looking at whether there is any vision-threatening elements. If there is any vision-threatening elements, then I'll liaise with the TB physicians and say that I do not have time to start the ATT on the same day. They might not be able to, see the patient on the same day, but I start the systemic steroids, depending if it's a vision-threatening element like macular edema or severe papillitis or extensive posterior pole vasculitis, and initiate the ATT within the next day or so. in this case, because the vision was 6.6, although there was some discongestion, I would not have possibly started the steroids straight away without the ATT cover, because we can actually wait for the ATT and start the steroids, simultaneously after starting the ATT, because there wasn't much of a vision threat. The other thing I wanted to ask was, did you actually investigate along the lines of syphilis and HIV?
ma'am.
And
Yes,
HIV
everything
as
was
well.
done before
Okay.
starting ATT.
Yeah, so just to add that you need to consider the possibility of whether this is syphilitic and also HIV in these cases. Thank you.
Thank you. So to summarize, whenever you see suspected unilateral or bilateral vasculitis, do proper imaging and confirm the extent of vasculitis, involvement of arteries and veins, and proper communication with the pulmonologist. If you suspect TB, do communicate with your pulmonologist and consider ATT. Okay, thank you.